The basic eye examination is an important part of a thorough history and physical examination. There are many systemic diseases with ocular manifestations that can be detected by a primary care physician. Examples of these are AIDS, malignancies, child abuse, hypertension, and diabetes. The basic parts of the eye examination are visual acuity, external examination, motility, visual fields, pupils, penlight examination, and direct ophthalmoscopy. The first step is to determine the patient's level of visual acuity. This is done prior to any manipulation of the eye or shining any lights into the eye. This will give you an idea if there's any visual problems that might need further investigation. To do this, use a near card such as this one. Have the patient cover one of their eyes. Hold the near card approximately 14 inches from the patient's face. Ask them to read the smallest line of numbers that they can.
428739.
Have them cover their other eye and do the same.
428739.
Visual acuity is recorded as 20 over blank. Perfect visual acuity is 20/20. What exactly does this mean? The numerator is the distance from the eye chart in feet. The denominator is the distance at which a person with normal vision could read the same line. In our example, 20/40 vision would mean that this person can read letters only at a distance of 20 feet that a normal person could read at a distance of 40 feet. If 20 feet is the standard distance, then how can visual acuity be checked at 14 inches? As the diagram shows, a 20/20 letter at 20 feet subtends an angle of 5 seconds of arc. Visual acuity can be checked at any distance as long as the size of the letter at that distance also subtends an angle of 5 seconds of arc. Therefore, the 20/20 letter at 14 inches is much smaller than the 20/20 letter at 20 feet, but both subtend an angle of 5 seconds of arc. What if your patient's visual acuity is so poor that they can't see any of the numbers on the near card? Then have your patient cover one eye and ask them to count fingers on your hand. How many fingers do you see?
1.
If they're unable to count fingers, then the next step is to see if they can detect hand movements. If they're unable to detect hand movements, shine a light in their eye to see if they can detect that. If they can't see a light in their eye, then their vision is recorded as no light perception. Record their vision as the highest level of perception, for example, counting fingers if they're able to do that. The next step of the examination is the external inspection. Look closely at your patient's eyebrows. Look at their upper and lower eyelids. Look for any swelling or redness around the eyes. Here's an example of a patient with xanthelasma, or cholesterol deposits beneath the skin around the eye. This can be indicative of very high blood cholesterol levels. This patient has an excess of thyroid hormone that causes bulging of his eyes and retraction, or pulling back of both upper and lower eyelids. The next step of the evaluation is ocular alignment and motility. Use your penlight to create a reflex on the cornea of each eye. The normal corneal light reflex should fall on the same position in each eye. Eye misalignments are named as follows. Esotropia means that an eye turns in. Exotropia means that an eye turns out. Hypertropia means that one eye is higher than the other. And hypotropia means that one eye is lower than the other. Next, have your patient look at a target while you move it in the various directions of gaze. Have them look right, up and right, down and right, left, up and left, down and left. This can best be remembered as resembling the letter H. Each of the 6 positions of gaze isolates the action of one of the eye muscles. Look for symmetry between the 2 eyes. Overaction or underaction might indicate nerve or eye muscle disease. Here are some examples of eye misalignments. This young girl has a dysfunction of her third cranial nerve, causing a weakness of her left medial rectus muscle. For this reason, her left eye deviates outward and does not move normally toward her nose. This elderly woman has a paralysis of the lateral rectus muscle in each eye due to head trauma. This causes her eyes to turn in considerably, and neither eye will move completely to the side. Next, bring your target slowly closer to the patient's eyes. The normal response is to see the eyes turn in and for the pupils to constrict. Next, test your patient's peripheral visual field. This gives you an idea of your patient's side vision. Have them cover one of their eyes. With their open eye, have them look at your open eye. You close one of your eyes as well, corresponding to their closed eye. Have them maintain fixation on your open eye and not move away from it. Bring your hand in from the side while wiggling your fingers and ask them to identify when they see it.
Yes. 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 Yes.
Do this with the other eye as well. You should test at least 6 positions to adequately map your patient's peripheral visual field. A normal patient has a wide field of peripheral vision. Tell me when you see my fingers. This patient has a deficiency of half of his visual field in each eye. This can be caused by a stroke.
Okay. Okay. Okay.
This would be the patient's view of the world. As demonstrated here, half of his visual field is missing. Next is the pupillary examination. While your patient fixates on a distant target, look at the size and shape of each pupil. Shine your light into one of the eyes. This should cause constriction of the pupils in both eyes. The constriction of the pupil in the first eye is the direct response, while the simultaneous constriction in the other eye is the consensual response. Here is an example of a patient with a light shown in his right eye. As you can see, both pupils constrict as a result of the light in one eye only. However, when the light is shown in his left eye, neither pupil constricts. That is, both the direct and the consensual pupillary responses are abnormal. This can indicate a disease of the retina or optic nerve in the left eye, and he likely has poor vision in that eye. Let me demonstrate the various structures on this schematic eye. The conjunctiva is the thin white covering of the eye. The sclera is the tough white coat of the eye beneath it. The cornea is the clear central part of the eye, through which you can see the colored iris and the pupil in the center of it. Behind the pupil is the lens. Its job is to focus images on the retina in the back of the eye. Use your penlight to illuminate each of these structures. Then have the patient look right, left, up, and then down, while you inspect the conjunctiva and the sclera. Here's a patient with abnormal pigmentation on the surface of his sclera. This is called ocular melanocytosis. Here's another patient with a severe cataract, which is an opacification of the lens in the eye. Next, you will perform direct ophthalmoscopy to assess your patient's ocular media and retina. Dilating drops should be used because they give you the best view of the retina. There are only 2 contraindications to using dilating drops. 1, narrow angle glaucoma, and 2, an altered mental status that requires periodic assessment of the pupils. These complications can easily be managed in a medical setting. Get to know your ophthalmoscope and its parts. This button turns it on and adjusts the light intensity. This dial adjusts your focus. Hold your ophthalmoscope like this so that you can adjust the focus during the examination. Your right hand and your right eye should be used to examine the patient's right eye, and your left hand and left eye to examine the patient's left eye. Failure to do this can put you nose to nose with your patient and result in a very awkward situation. First, at arm's length, focus on the front part of your patient's eyes, looking for a normal red reflex. A normal red reflex indicates that there's no obstruction between you and your patient's retina. I prefer to put my hand on my patient's forehead, both to stabilize their head and prevent me from bumping into them as I move closer. Here's a patient with an abnormal red reflex in his right eye. Here is a partial cataract causing an abnormal red reflex. Next, move slowly closer to your patient's eye, keeping your red reflex directly in the center. I cannot overemphasize how important it is to get very close to your patient. You're trying to view the retina through a very small opening. This photograph demonstrates the enhancement of your view as you get close, closer, and closest. As you move slowly closer, refocus your ophthalmoscope until you have a clear view of the retina. Here's a normal retina. Your view will include only a small section of this picture. Find a blood vessel and then follow it centrally until you can see the optic nerve. Look closely at the nerve and study its color, the clarity of its margin, and the size of its cup. The cup is the small yellow depression in the center of the nerve. Next, study the arteries and veins which emerge from the nerve. Follow them in all four directions: superior temporally, inferior temporally, superior nasally, and inferior nasally. The vein should be thicker than the arteries and in approximately 3:2 ratio. Next, have the patient look at your light. You will then be looking at the patient's fovea, which is the center of the macula, the area of most precise visual acuity. Here's an example of a patient with a swollen optic nerve due to a brain tumor. In this picture, you cannot see the optic disc margin, the optic cup, or the blood vessels as they emerge from the nerve. Here's an example of retinal disease caused by diabetes. This patient has small hemorrhages and exudates in the retina. Exudates are collections of fatty material that result from leaking blood vessels. This patient has a retinal infection caused by a virus that is associated with AIDS. This requires treatment with intravenous medications to prevent the rapid onset of blindness. Now I'll do the exam in sequence. All you need is your near card, a penlight, and your direct ophthalmoscope. Let's check your vision first. Cover your left eye with your hand. Hold this, please. What's the smallest line of numbers that you can read?
428739.
Cover your other eye, please. What's the smallest line of numbers that you can read there?
428739.
Good. Let me have a little closer look at your eyes. Now I'd like you to look at this target and follow the target without moving your head. Now let's check your peripheral vision. Cover your left eye with your hand. I'd like you to look here towards my open eye and tell me when you see my fingers wiggle.
Okay. 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 Okay.
Cover your other eye, please. Do the same. Look here.
Okay. Okay. Okay.
Keep looking right here, please.
Okay. Okay. Okay.
Good. I'm going to have you look straight ahead. I'm going to look a little more closely with this light. Look right, look left, look up, look down. Look straight ahead. Look at my light. And look there. Look at my light. Mastering the basic eye exam can help you in your diagnosis of systemic diseases and can also allow you to detect ocular abnormalities that might require referral to an ophthalmologist.